Hello, I'm Lauren Wagner. I'm one of the palliative care attendings at Mount Sinai, and I'll be talking about discontinuing life-sustaining treatments today, or the withdrawal of non-beneficial treatments while maintaining care. So this can apply to several different interventions, including palliative extubation, de-escalation of non-invasive ventilation versus discontinuing pressors, dialysis, or artificial nutrition. And the principles that we'll talk about really apply to all of those, but we'll largely focus on palliative extubation since it's the most kind of involved in terms of symptom management. So I have no disclosures. And I think just when we're thinking about why this is challenging, largely we feel uncomfortable when we're talking about it. It can be emotional for us. It's often emotional for patients and their families. And then when we're thinking about symptom management, if our goal is to make sure that someone is comfortable, we really want to make sure that we're actually doing that. So there's a bit of added kind of pressure in making sure that we're really doing well with symptom management. So the overall goal of the talk is to think about the principles that discontinuing life-sustaining treatments are based off of, to utilize a framework on how to have these conversations, to manage common symptoms that come up, and to have a clear picture of the role of different members on the interdisciplinary team and how they're helpful and needed. And then this picture is just meant to kind of highlight that we're very good at keeping people's bodies alive, but that doesn't mean that it always aligns with people's goals or their values. And so these are some of the concepts that withdrawing life-sustaining treatments is based off of. So the goal of withdrawing life-sustaining treatment is to remove treatments that are no longer desired or do not provide comfort or causing active suffering for the patient. Actions whose sole goal is to hasten death are morally and legally problematic. Withholding life-sustaining treatments is morally and legally equivalent to withdrawing them. Any treatment can be withheld or withdrawn, and when circumstances justify withholding one life-sustaining treatment, consider holding all of them, since keeping the other ones is likely to be going against our stated goal. And then withdrawal of life-sustaining treatment is a medical procedure. And withdrawal is considered to be ethically okay based off the principle of double effect, which says that it can be ethical to perform an act that may cause a foreseen but unintended harm as a consequence of bringing about a good result. So the criteria for that principle involves saying that the act itself is good or neutral, so the act cannot be a harmful thing. So for palliative extubation, extubation itself is not inherently harmful. The intended effect of that act needs to be good, which for us would be making sure that someone's comfortable or avoiding prolonged suffering. So the effect that we're hoping for is not death itself, or not saying that death needs to happen for someone to be comfortable. And then the goal needs to outweigh the bad in a circumstance that is serious enough to warrant causing harm. So for us, again, that serious situation might be where someone's time is short no matter what we do. And the good here is not causing suffering by prolonging that dying process, even if removing the ventilator does in fact hasten their death. So overall, our goal is the removal of unwanted treatments, not hastening death. And when we're defining palliative extubation specifically, it refers to the removal of mechanical ventilatory support when, based on an individual's goals of care, it's thought to be prolonging the dying process rather than helping to support them through a reversible illness. And in removing the endotracheal tube, we anticipate that this will likely allow for a natural death to occur. And this slide is just a reminder to be mindful when we're talking about palliative extubation. There's several different ways of phrasing it, and some of them, like ventilator liberation or compassionate extubation, can be very strongly moralizing and kind of put our own biases into the equation. Conversely, to me at least, things like terminal extubation sound overtly scary for families. And so it's just to kind of make sure that we're being thoughtful and also objective when we're talking about it. So we'll go through one case. So for Mrs. K, she is an 86-year-old woman with advanced dementia, transferred from her nursing home with an acute change from baseline mental status. In the ED, she was found to be hypotensive, tachycardic, and minimally responsive in the setting of an aspiration pneumonia. She was intubated and was started on pressors and antibiotics. We're now at day 5 in the ICU. She has a rising lactate with continued increasing pressor requirements and a worsening AKI. Her daughter is at bedside now, and you're consulted for assistance with goals of care. So when we're thinking about having these conversations, the goal is to allow our patients and families to make decisions based off of what's most important to them. There's several acronyms out there on how to have these serious conversations, like SPIKES or REMAP. We'll use REMAP here and kind of briefly go through it. It can have its own lecture, so we'll just kind of briefly run through it. And it's meant to be not a strict step-by-step, but more as a framework to try and help in these kind of conversations. And so we want to start with the reframe, which is basically our headline or the big picture that we're hoping that patients and families take away from our update. And so this looks like checking in first to see what they've heard from the team about how they're doing. And then based on where they're at, kind of giving our headline, which in these situations oftentimes might include something like, despite everything that we've been doing, we think that time is shorter than we'd like. Or she is getting worse and we're very worried she may die no matter what we do. Or perhaps for a different patient, we're worried that she's at a point where she will not be able to breathe without the help of the ventilator moving forward. And so then the next part of the conversation is responding to emotions that are very likely to be present after delivering serious news like this. And so although high emotions can be very stressful for us, they're oftentimes a good sign that someone has actually heard the news that we've given. So we use another acronym called nurse statements when we're thinking about how to respond to emotions. And the goal of these is not to fix or resolve the emotion, but to kind of make space for emotions and not just run past them. And so again, kind of briefly running through nurse statements, as this isn't the whole topic of what we're going through, but we think about using naming statements. So this is scary, this is frustrating, this is overwhelming. We also use understanding statements. Somewhat comically, we're not ever saying really, I understand what you're going through, or I understand how shocking this is, because we can't, since we're not them. So instead, we're saying things like, I can't imagine how shocking this must be to hear, or I can't imagine what must be going through your head right now. And we also use respect statements like, you've been doing such a good job taking care of your mom. You've been such a good advocate for her. We can use support statements involving things like, our team will keep following with you through this process, or our teams are around if any questions come up. And then there's also explore statements, which can be really helpful for statements or questions for patients where you might think that you kind of know where they're coming from or what's going through their mind, but it's also possible that it's something else. So when someone says things like, I never thought we'd get to this point, or it is what it is, sometimes we kind of assume that we know what they mean by that, but just by asking things like, what do you mean? Or can you tell me more? You can get a clearer picture of where their head is at. And then finally, sometimes just sitting quietly and kind of being silent is helpful to kind of make room for emotions as well. And so in the second part of this conversation, the goal is, again, to really map out people's values so that we can match our recommendation to what's important for them. So for this talk, thinking about people for whom we might be recommending discontinuing certain life-sustaining treatments, the things that might signify that this is the next best step for them would be people who are clear that they would not want to be kept alive on machines for the rest of their lives, or people who say that it's not okay with them if they can't interact with their family or the world around them. Maybe other people who say that independence is very important, family or being at home is the most important thing to them. Those people might be people where their values kind of align with discontinuing certain treatments. And so then based off of those values, we're then aligning with someone by essentially summarizing what they're saying and making sure that we have the correct interpretation. So saying things like, it sounds like being kept alive on machines in a state where she couldn't interact with us wouldn't be okay with your mom. Does that sound right? Kind of checking in. And if you're wrong, totally fine. That's helpful information as well. But if a family says like that, they confirm, then asking if it's okay to kind of make a recommendation based off of that. So when we're making that recommendation for something like palliative extubation, one of the big things to make sure that we're emphasizing is how we're going to continue caring for their patient. We hear people say withdrawal of care all the time, and we really kind of try and avoid using this phrasing because it makes it seem like we're just recommending taking things away from the patient rather than what we're actually doing, which is still caring for them, but just with a different focus. So in our recommendation, we're thinking about things that we will do, how we will give medications as needed, and then things that we'll avoid or discontinue as we don't think that they're helpful anymore. And if they're in agreement with that, then we can check in about the timing of when that might be by seeing if there are other people who want to be present or who at least want to come visit. Also important to check if religion or spirituality is important. Are there any rites or rituals that we should be aware of that are important that need to happen? If there are young children that are involved, how can we be helpful? Should we have child life involved? Does family want them to be present or not present? We also want to think about where we're doing a palliative extubation, whether that's in an ICU, maybe a palliative care unit if there is one, or at least making sure that someone has a private room. And then again, we also want to think about all of the other ways that we care for people. So are there things that we can add in the background to make them more comfortable, things like music or art? And then finally, after the meeting, making sure that in our documentation, there's things like DNR, DNI, but also being clear as we can in our plan for the time leading up to the extubation about what we will be doing, what we will not be doing. So for our case, her daughter agrees that her mom would not want her dying process prolonged on a breathing machine. She agrees with a recommendation for palliative extubation later in the week after additional family members come, and then we're planning for Thursday at 2 p.m. in the ICU. So on the day of the extubation, we want to again meet with the family, maybe less formally, but just to make sure that we're all on the same page. And so this would look like checking to see who from family will be present. Depending on the clinical situation, maybe you're offering for family members to be at bedside for the actual extubation versus asking to step out or not offering to be at bedside, with the understanding that people might ask, and that's okay as well. It's also important prior to this meeting to know who from the interdisciplinary team needs to be present for both this meeting and the extubation, particularly if our chaplains or social workers have made a strong connection with the family. That can be very helpful to offer counseling and support. And then we want to make sure that we're giving a very clear explanation on what to expect. So this looks like talking about what the procedure entails, including meds that we might give, symptoms that we're looking out for, and things that we're going to be discontinuing, like an NG tube, antibiotics, suppressors. Even if we think that it's obvious that we'll discontinue these, they can be tied to emotions for families. So it's better to discuss that now and answer any questions that come up rather than have it come up later or during the procedure. We also want to make sure that we're emphasizing what our goal is, which is symptom management using things like opioids and benzodiazepines. And just of note, there was a study from 2004 that looked at the relationship between the average hourly opioid and benzo dose in the hour prior to withdrawal and the time to death after withdrawal, and they found no significant relationship between the dosing. So just kind of reiterating to families that we're using them for symptoms, not to shorten time, and that even if we're giving them, they will not be shortening or hastening someone's death. And we also want to be clear that that with the families that we'll keep checking in both during and after the procedure. We won't just leave or abandon them afterwards. And we also want to talk about things like turning off the vitals monitoring machine. We typically recommend turning it off since we're giving meds based off of symptoms rather than vitals. Vitals aren't necessarily an accurate predictor of time, and they can be distressing for families to see. However, some families do really want to have them there because they're kind of using them as a marker for themselves. And so in that scenario, that's fine. We just kind of make sure that we turn the vitals monitoring machine to a comfort mode so that it's not doing alarm or making alarms while we're going through the procedure. And then finally, if it hasn't come up already, it's also important to talk about prognosis and what to expect. So if a family is asking about it, it's important to first just kind of pause and address any emotions in that question, because many times when people are asking, it's actually an emotional question and they may not necessarily want to hear the actual answer. So you can just check in saying things like, before I answer, can you tell me more about where this question is coming from? For family members who are not asking, you can also check in to see if it's okay if we talk about kind of what to expect in terms of time. However, again, sometimes people might not want to know, so it's also okay if they say no, that they don't want to hear. So if you're getting a patient or a family that does want to hear, then you also want to check in if there's anyone else in the room. Is it okay if everyone hears the information? Because again, not everyone wants to hear. And then also asking about how people prefer to receive information. So sometimes people want physical time and what to expect with that versus looking more at the big picture as far as signs and symptoms that they should expect to tell them that time is short. So you just kind of check in to see which they might prefer. And then also, as we know, we can never give an exact prediction. So just kind of making sure to acknowledge the uncertainty and use ranges if we're giving time. And it can be difficult for us to predict that time. So when we're thinking about how to give or how to predict the range for that time, there was a lit review that looked at 7 larger studies that showed 45 to 76% of patients passing within 1 hour of palliative extubation. The overall population for the SLIT review was described as neurocritical ICU patients and those who were going for organ donation after cardiac death, not necessarily brain dead patients, though. For me, this number seems high, but can be kind of helpful in our prognostication. There was one of the studies also talked about, they had a 93% of 1,500 patients in their ICU passed within 24 hours, versus another one, though, was smaller, only with 435 patients, but they actually had 30% who survived to discharge to hospice outside of the hospital. So all of that to say, this can be helpful. We can kind of think about ranges of maybe hours to days, but we can never know for sure. There separately, though, have been other studies looking at predictors for a short time or for shorter time. Interestingly, one of the studies kind of said that clinician gestalt was actually a significant predictor for when time was shorter. And the other factors listed here are kind of obvious, basically pointing to sicker patients are likely to have shorter time. And then when people are more interested in hearing about kind of big picture or symptoms to look out for, we can talk about how some of these are the symptoms that we're expecting to see. Obviously, depending on where the patient is already at, some of these might be more or less relevant. So like depending on their initial level of wakefulness prior to extubation, we might be thinking about decreasing periods of wakefulness or increasing confusion. Importantly, I think it's important to note that even without medications, we would see this as the body starts to wind down, and letting families know that it's not necessarily medications that are doing this. We can also talk about how we anticipate changes in breathing pattern with more periods of paused breathing followed by bigger breaths, and talk about how this pattern is normal and expected, even though it can be a little distressing to see. And then also talking about increased secretions, how they're not typically uncomfortable for patients, though they can again be distressing for us to see. And we also might see changes in extremities as well. And then for someone who might be more awake, maybe someone who you're de-escalating from high flow nasal cannula or stopping dialysis, you might note that they'll likely be eating or drinking less as, again, the body kind of starts to wind down. So for our case, depending on whether they want to hear about time versus big picture, you might say for your mom, time is likely in the range of hours to days, though it's possible it could be shorter. Sometimes people also surprise us and stay with us for longer. In that scenario, we would continue to make sure that she's comfortable. Versus if you've already kind of talked about symptoms to expect, you might say, we'll let you know if we see signs that time might be shorter or longer. And if you notice any new symptoms that you're worried about, please let us know. So in addition to meeting with the family, we also just want to think about other interventions or medications that we're currently doing for the patient and what our plan is for each of those. So for tube feeds, we recommend stopping them about 12 hours before the planned extubation to reduce secretions and to decrease that aspiration risk. Though again, very important to let family know that this will happen, as there's oftentimes emotions attached to nutrition, since people will sometimes feel like not feeding someone can feel like they're starving them. So there's oftentimes emotion related to that. So just important to let people know. If someone has an AICD, this should also be turned off in conjunction with cardiology so that they don't get shocked. However, a pacemaker is okay to leave on because it's not going to keep someone from passing, since we're typically at a point where basically the myocardium is too weak to respond to pacemaker signals. If someone is on paralytics, we'll also plan to discontinue these around 2 hours before the extubation, or as long as needed for the effects to wear off, since it's not comfortable to be paralyzed. And we'll oftentimes recommend stopping lab draws, dialysis, meds not aimed at comfort leading up to the extubation, since we don't think that they're providing a benefit. Though sometimes if we're trying to give families time to come visit, it might make sense to keep some of these things on. We'll also typically stop IV fluids to reduce the risk for secretions or potentially third spacing. Though again, sometimes people have emotions attached to kind of perceived dehydration, similar to tube feeds. So it's just important to discuss about kind of why we'd be stopping them. And then just kind of thinking about the things that will stop more at the actual time of extubation. Typically, this will look like stopping pressors or antibiotics if they're not already stopped. And then although we've already stopped the tube feeds, we'll also remove the NG tube or the OG tube at the time of extubation. And then for us, when we're thinking about which medications and the dosing to start for someone, we want to get a sense of what we're anticipating for the patient in terms of symptoms. So similar to prognosis, I think these higher risk factors are all fairly obvious, but you might anticipate more dyspnea in someone who has an insult to their lungs or is overbreathing the vent, or someone who is more awake, specifically someone who's like GCS greater than 8, or someone who is already needing higher doses of medications to keep them comfortable even with the vent. There's been some studies looking at a terminal wean versus an immediately extubating someone, and the wean would look like basically a pressure support trial where the FiO2 is at 21, PEEP is at 0, tidal volume 0, and respiratory rate is set to 0, with the goal of basically moving more slowly to make sure that we're able to control any symptoms that arise as we lower the settings. And they did see a statistically significant decrease in the instances of like gasping, severe tachypnea. They also, though, noted that there wasn't a difference in essentially grief between the group that did the weaning versus an immediate extubation at 3 months for families. And they also noted that weaning may open the door for families to change their mind midway, or that some families feel worse with prolonging things, and that weaning or moving more slowly is harder on staff. So all of that to say that it's something that you consider if you're very worried about symptoms being uncontrolled as kind of a stepwise fashion. And then another risk factor for symptoms that you might see, this would be the risk for stridor afterwards. And if respiratory therapy is not seeing a cuff leak, then that would be a higher risk for things like inflammation, leading to a higher risk for stridor post-extubation. And just thinking about how to actually assess dyspnea after the extubation in these patients, we can use the ARDOS scale to gauge, which is basically just taking our kind of clinical gestalt a bit more and making it a bit more objective. So looking at things like the heart rate, the respiratory rate, restlessness, accessory muscle use, grunting, nasal flaring, if someone's looking scared or uncomfortable. And then if you're seeing kind of three points, this would indicate doing something to change the regimen or increasing the doses. For pain assessment, there's different scales that you can use, like the behavioral pain scale or the critical care pain observation tool, which are essentially looking at both of these, kind of looking at the same thing for nonverbal signs of pain, including facial expressions, vocalizations, movements, and rigidity. And so after assessing, we think about what meds to actually give to try and prevent dyspnea during and after extubation. Every patient obviously is very different, so it's a little hard to give necessarily kind of exact or strict guidelines about what to do, but these are kind of meant to be general recommendations that can be kind of used as a framework on where to start. So overall, for dyspnea, we'll be using opioids for dyspnea management, and we'll want to give a bolus about 15 to 30 minutes before the actual extubation. If someone is already on a continuous infusion of morphine, hydromorphone, or fentanyl, you can give a bolus of about 2 times the rate of the continuous infusion and then titrate to comfort. Also, if someone's on an infusion already, it's easier for nurses to give boluses or PRNs more immediately from the bag, versus someone who has been receiving opioids but is not on an infusion. So for those patients, you can consider giving a bolus, potentially like 1 to 2 times what they've been receiving, and either consider starting a standing doses if their overall usage is lower, versus a continuous infusion at a rate of 50% of what that effective bolus dose is. And then for people who are opioid naive, we plan to give a bolus dose based off the numbers that I'll talk about on the next slide, and give doses every 10 to 15 minutes until they're comfortable. And then depending on usage, again, maybe you'll consider starting standing doses versus a continuous infusion if they're needing quite a bit. So these would be the potential starting doses for someone who's opioid naive. If someone has no liver or renal dysfunction, you can consider starting morphine 2 to 4 milligrams every 10 to 15 minutes as needed. For someone who does have liver renal dysfunction, you would want to start with hydromorphone 0.2 to 0.4 every 10 to 15 minutes as well. Even though someone is comfort care, we're using hydromorphone here to kind of reduce the risk of side effects and the risk for neurotoxicity. So for our case, we'll kind of go through 3 different scenarios of what that would look like. So in scenario 1, she's comfortable on an infusion. So you would use double the continuous infusion as a bolus prior to the extubation and then titrate to effect afterwards. So if she's on 2 milligrams an hour, you might give a bolus of 4 milligrams and then titrate as needed afterwards. And this would be the same concept for both hydromorphone and fentanyl. Though for fentanyl, keep in mind that you might look to do a shorter interval, like every 5 to 10 minutes, since it's faster on and faster off. So in scenario 2, she's comfortable on standing doses on 0.4 every 6 hours. And obviously, the recommendation for this is definitely going to vary based off of how the patient looks to you and other factors, but you can kind of use this as a rough framework again. So maybe you might give 1 to 2 times that standing dose, 15 to 30 minutes prior to the extubation, and then consider starting a continuous infusion at half of that effective dose. So maybe you're giving 0.4, 0.8, 15 to 30 minutes before, and then starting an infusion. If you gave 0.4, maybe starting the infusion at 0.2 milligrams an hour with a bolus or a PRN at 0.4. And then in scenario 3, for someone who's opioid naive and they do not have renal or liver dysfunction, you might start morphine 2 to 4 milligrams for her and give boluses every 10 to 15 minutes until she's comfortable, and until you found your effective dose. So let's say it takes morphine 4 milligrams twice in 20 minutes for her to be comfortable. The new effective dose would be 8 milligrams moving forward. So for anxiety or agitation management, it's basically the exact same concepts as opioids, but with benzodiazepines instead. So if someone is already on a continuous infusion like midazolam, you can give them a bolus that's double the rate and then bolus afterwards as needed. Versus if someone is not on an infusion, you can just give a bolus about 15 minutes beforehand and then consider whether you want to start standing doses versus an infusion based off their symptoms. So for someone who has not been on any benzodiazepines at all, we'll typically use lorazepam or midazolam, just with a small difference that with midazolam, you might also, again, shorten your frequency to every 5 to 10 minutes for shortness, or because it's faster on and faster off. And I won't go through necessarily a sample for this case because it's the exact same concept as opioids, but typically for patients, we'll use both opioids and benzodiazepines for people who are being palliatively extubated, particularly if you're worried about symptoms. And then thinking about other symptoms that we encounter, many people are worried about secretions. And we see these because with decreased wakefulness, patients lose their ability to clear and swallow the roughly 2 liters of saliva produced per day. So as air moves over the secretions, pulled in the oropharynx, it produces a gurgling sound that people often call the death rattle. And we don't think that it's uncomfortable for patients, but it can be very unpleasant. It's distressing for us as well as their families. And so people oftentimes want to do something about it. And so there's 2 types, the first being salivary secretions, which are higher up, versus bronchial secretions, which are lower down. There's not great evidence for management of either of these. We're more treating ourselves and families, but when we're talking about going after symptoms, we're thinking about the salivary secretions that we can sometimes suction, or we can try and decrease with medications. So again, there's not good evidence for the efficacy, and there's a possibility of giving people side effects. So pharmacologic management is not recommended. Initially, we kind of tried to just counsel family members on what to expect. We try and if there's secretions, kind of those salivary secretions, we can try and suction them, but avoid doing deep suctioning because we don't think it'll be effective and can be more uncomfortable. And then we also want to think about the interventions that we're doing still that might be increasing their secretions. So if someone's on fluids or artificial nutrition, or if they're on a bunch of medications that have a lot of fluid, trying to decrease some of those to reduce the secretions that someone might have or make. So overall, we're not necessarily recommending pharmacologic treatment, but it's also very hard not to do anything, particularly if the family's distressed. So if we're going to give meds, this would be giving glycopyrrolate. It has a quick onset within about 1 minute, and it doesn't cross the blood-brain barrier. So it's less likely to cause side effects like sedation or delirium. But also we want to keep in mind that sometimes when people have thick secretions, it can actually just dry them out and make it harder for them to clear. So again, not always helpful. And the use of other anticholinergics like scopolamine, atropine, and hyoscyamine are even less recommended as they do cross the blood-brain barrier, and so can cause more side effects like delirium and sedation. And then also when we're thinking about things like a scopolamine patch, it's going to take several hours to even see the effect. So it's less helpful in this scenario regardless. So once we have our medications planned and we've talked with the family, we're thinking about what to do kind of immediately before the extubation. So for the patient, we want to make sure that we're giving those opioids and benzodiazepines about 15 to 30 minutes before the extubation and removing any other tethers that make sense to try and make them as comfortable as possible while still keeping the NG tube in place. For families, we're making sure that whoever wants to be there is ready and making sure that the room is set up for them. And then from the team side, we're making sure that we have all the supplies that we need, including 1 to 2 additional boluses in case we need them, as well as things like towels and pads and suctioning equipment. And then we're also gathering our team to talk through kind of our roles and go through anticipatory guidance for things. And so what that meeting looks like is including kind of thinking about who is important to have at this meeting and for the extubation. So for our nurses, we're talking about what symptoms to expect, what supplies that we need to have ready, making sure that the vitals machine is either off or on with comfort mode. For our respiratory therapist, we're walking through the procedure to see if there's any concerns that they might have. For our chaplains, if they have a relationship with the family or the patient, is there anything that we should be aware of for them? How we can be helpful. Similarly, with our social workers, it's helpful to have any guidance if they have a relationship. And then if the patient speaks another language, I think we'd all agree that having an in-person interpreter is ideal, though obviously can be challenging and not all the time available. So if it has to be over a phone, just making sure that we have them ready and also that we're checking in with the interpreter beforehand so that they have a heads up about what to expect, because this is kind of a serious event that can be shocking for people, and to make sure that we're answering any questions that they might have about the procedure, to make sure that if we're explaining something, they understand what's going on to be able to also interpret. And then similarly for learners, we also just want to make sure that we're checking in with them about what to expect, even if we're not seeing an outwardly strong emotion, just kind of checking in both before and afterwards. So then moving forward with the actual extubation itself, typically with our respiratory therapist going through these steps. So first making sure that the vent alarms are silenced, and then we suction as needed beforehand. As we talked about, you can consider weaning to the FiO2 of 21 or PEEP to 0 and kind of making sure that symptoms remain controlled, though not necessary. For every patient. And then when you're ready, the respiratory therapy would deflate the cuff and remove the tube and NG tube under a pad or a towel to avoid distressing family that might be present. And then we suction afterwards as needed. And we oftentimes will extubate to room air, but sometimes family requests nasal cannula because they worry about dyspnea without supplemental oxygen. So you can also place them on a nasal cannula as needed per family. And then finally, after removing the tube, we turn off the ventilator and then eventually remove it from the room. So then from the nursing perspective, again, we'd have extra boluses as needed in case there's extra symptoms. And then after the extubation, we just make sure that the patient is cleaned and that we're doing things like moistening their lips and kind of making sure that they look comfortable. And then we'd ask them to remain at bedside afterwards to make sure that we're controlling any symptoms that come up. And just kind of thinking about alternate scenarios, if someone has a trach that you're leaving in place, then you don't deflate that cuff, as oftentimes there's secretions pooled around it. So deflating could cause things like coughing. And if there is an upper airway obstruction, like inflammation, infection, trauma, or a foreign body, consider leaving the ET tube in place and just disconnecting them from the vent. If there is post-extubation stridor, then you can consider things like racemic epinephrine for an awake person. Or if they're not awake, there's some evidence for methylprednisolone or dexamethasone for non-palliative extubations or medical extubations that they can reduce stridor or reintubation. And then if you're worried about a bleeding risk or that removing the ET tube will cause bleeding, you can consider leaving it in place. Or if there is bleeding, then you can think about using dark towels to clean or kind of cover blood to reduce family distress. And then after the extubation, we're really monitoring for any dyspnea, anxiety, agitation that might come up. And we're giving meds as needed every 10 to 15 minutes until symptoms are controlled, and then titrating as needed after that. And apart from symptoms, then we're just making sure that things are as comfortable and peaceful as possible. So removing other medical supplies that we don't need, repositioning the patient to make sure they look comfortable, adding music as needed, anything that can kind of focus on making things comfortable. And If family is not at bedside, then we can ask them to come back in, and then we stay available for frequent check-ins. Then again, as needed, we use the opioids, thinking about kind of now that we've done an extubation, if we're kind of checking in later, if someone doesn't pass very quickly, we check in again to look for any symptoms and can give opioids and benzos every 10 to 15 minutes as needed. When we're thinking about changing a continuous infusion, we're not typically reaching a steady state for 4 to 6 hours, but given that time might be shorter for a patient, if you're seeing that someone's needing more than one PRN an hour after we've kind of initially made them comfortable, then you could consider increasing the continuous infusion. And again, just checking in to make sure that symptoms are controlled. And then after the extubation, or if a patient passes quite quickly, it's also important to debrief with the team, not just to see if there's things that we could do better, but also to address any current concerns or any emotions that may have come up. So for our case, again, this is Miss K, who had a rising lactate with increasing pressors and worsening AKI, and her daughter decided to transition to comfort-focused care, including a palliative extubation. So overall for her, we're thinking about which is not an ethical principle that relates to withdrawal of life-sustaining treatments. A, withdrawing or withholding and withdrawing life support are equivalent. B, the goal of withdrawing life-sustaining treatment is to hasten death. C, there's an important distinction between killing and allowing to die. D, the doctrine of double effect provides an ethical rationale for providing relief of pain and other symptoms with sedatives and palliative extubation, even when this may have the foreseen but not intended consequence of hastening death. So which of these is not an ethical principle? That would be that the goal of withdrawing life-sustaining treatments is to hasten death. And again, just kind of reiterating that the goal is to remove interventions that are no longer desired or don't provide comfort or are actively causing harm, not to hasten death. For this question, what information is most helpful in making a decision regarding discontinuation of life-sustaining treatment? A, underlying illness severity. B, values and treatment preferences. C, age. D, social history. Very clearly, we think about highlighting that the point of this conversation is to make a recommendation for patients and their families to come to a decision based off of their own values and what's important to them. And then when we're thinking about medications, which medications should be administered prior to discontinuation of mechanical ventilation, haloperidol, morphine, lorazepam, or both morphine and lorazepam. And we use morphine and lorazepam or a benzo for dyspnea for opioids. And then for anxiety and agitation, we use benzodiazepines. These are my references and any questions.